Hi everyone, this is Tim, your lecture instructor for Block 3, and today we're going to be covering the PowerPoint on Chapter 70, primarily or specifically Parkinson's disease. So the first question I have is, what is akathisia? It's either going to be restlessness or urgent need to move around and agitation, or it could be very slow voluntary movements and speech, or it could be impaired ability to execute voluntary movements, or D, a sensation of numbness or tingling, or pins and needles sensation. And your answer is going to be A, which is restlessness and urgent need to move around and agitation. Akathisia is restlessness and an urgent need to move around and agitation. Bradykinesia is very slow voluntary movements and speech, which kind of makes sense because brady means slow. Dyskinesia is an impaired ability to execute voluntary movements, and paresthesia is a sensation of numbness or tingling or pins and needles sensation, which kind of makes sense because your patients who have paresthesia, it's almost like you sleep on your arm and you sleep on it for too long and you start to lose the sensation or the circulation's kind of cut down. You get that pins and needles sensation. That's paresthesia. So, Parkinson's disease, it's a slow progressive neurological movement disorder associated with decreased levels of dopamine. So the manifestations are, there's 4 of them. So we have the cardinal, which is tremor, rigidity, bradykinesia, and akinesia, postural instability. We also have autonomic, which is sweating, drooling, flushing, orthostatic hypotension, gastric and urinary retention. We have dysphagia, and we also have psychiatric changes, which is depression, anxiety, dementia, delirium, and hallucinations. So I think that you definitely, this is one of the need to know situations because, again, these 4 manifestations are very accurate to what I have actually taken care of and seen in the hospitals. So here's a chart of the pathophysiology of Parkinson's disease. Basically, in a nutshell, it's the destruction of dopaminergic neuron cells in the substantia nigra or the basal ganglia. So what the heck does that mean? Basically, the dopamine is decreased, and this actually impairs the extrapyramidal tracts of controlling complex body movements. So basically, dopamine is actually depleted, and this is how the tremors, rigidity, bradykinesia, and the postural changes start. So for medical management, treatment is going to be directed towards controlling the symptoms and maintaining functional independence. So again, with patients who have Parkinson's, they have the rigid and the tremors. Their fine motor skills are non-existent. And you just have to be able to do as much as you possibly can to keep them as independent as possible, especially for their ADLs, being able to walk and being able to do small tasks. Pharmacological treatment can be levodopa. This actually can be found on page table 70, which is -1. The table 70-1 can be found on page 2104. This is basically selected medications used to treat Parkinson's disease. They're all pretty good to know. I do believe that you should know levodopa, carbidopa, and how that actually works. And I also would like for you to know the cogentin, which is the anticholinergic agent. This will actually go over in class, so don't worry too much about that. But again, I would really like for you to be familiar with most of them, but the levodopa, carbidopa, and the cogentin are definitely the 2 main ones I need you to know. They also can do surgical procedures. This is a stereotactic procedure. This basically allows them to go in and manipulate some of the neurons and stuff, so that way they can try to slow down the tremors and the rigidity. We also could do neural transplantation, but this is an ongoing research and they're still working on that. So another question, is the following statement true or false? Parkinson's disease is slowly progressing neurological movement disorder that eventually leads to disability. And that answer is going to be true. Parkinson's disease is a slow progressing neurological movement disorder that eventually leads to disability. So as I mentioned before, what you want to do is try to give your patients the ability to and the tools to be able to be as independent as they possibly can for as long as they possibly can, because eventually medications either fail or it takes a long time for them to find the right one. And then when you do get on it, eventually it stops working, and the Parkinson's, as far as the symptoms, tend to take over. So you try to do as much as you can for as long as you can. The nursing process, the care of the patient with Parkinson's disease. So basically your assessment is going to focus on the degree of the disability and function of the patient. Again, we mentioned the ADLs, the IADLs, and the cognitive function. So you want to really assess what they can do and what their abilities are. You also want to assess medications and the responses to the medications, because again, some patients will respond to levodopa or carbidopa, and some will actually do really well on it, and some of them won't. Some of them will need low doses, some will need higher doses. So you really want to kind of find out where they are in that process. You also want to assess their emotional responses and their individual coping. This is a person who would probably, for the majority of their life, was able to function independently and live a very normal, healthy life. And then based on the neurological aspect of Parkinson's disease, eventually the tremors and the ability to do what they could do before is kind of diminishing. I would also assess the family for their coping mechanisms. Not only does this affect the patient or the person who has Parkinson's, but it also affects the people who live with them. What they were able to do once before, now they need help with, and that takes a toll on people that were not necessarily the person, the caregiver type, and now they're really having to step up and take care of someone else. So you kind of have to find out how they're coping with it too. The home care and educational needs, again, this is more of us assessing the patient and their family and find out what help they need and how they can get around to make sure that they are able to be as independent as possible, or if they do need help, making sure they get some of that help. This is a big factor, the risk assessment. Your patient that has Parkinson's, they do have a very hard time being able to walk. You probably want to have some sort of safety evaluation at their home to make sure that they're able to get all the things they need to be safe and to keep themselves up off the floor. You also assess the manifestations and potential complications related to the specific order. So again, you're looking at fall risks and aspiration precautions and making sure that they're able to do ADLs and kind of assessing the family to make sure that they get the help they need, or everything that they need to be able to help care for this patient. So for nursing diagnoses for patients who have Parkinson's disease, there obviously is a lot. Impaired physical mobility and the risk for activity intolerance. There's disturbed thought processes. There's self-care deficits, imbalanced nutrition. There's also constipation. With Parkinson's disease, this does tend to slow down the intestinal tract and also the neurons that are able to pull the fluids back into the intestines to keep from being constipated or slowed down also. So I kind of knew this, but it wasn't aware of how impactful it is based on Parkinson's and constipation. So I thought that was very interesting. They also have impaired verbal communication because of the Parkinson's ineffective coping and compromised family coping. We have deficit knowledge, and then we have risk for injury. So those are pretty good specific nursing diagnoses for patients who have Parkinson's disease. For the planning, the major goals may be improved functional ability, maintaining independence in ADLs, achieving adequate bowel elimination, attaining and maintaining acceptable nutritional status, achieving effective communication, and developing positive individual and family coping skills. So again, if you really kind of go back to the diagnoses, basically you're trying to prevent all these from happening, and that's what the main plan is. As far as improving mobility, daily program of exercise, keeping these patients as mobile as possible is what's going to keep them as independent as long as they possibly can. Patients who tend to sit in a chair or stay in bed tend to lose, whether it be muscle mass, strength, or the ability to actually be independent in walking. So I think the idea is that if you set up some sort of daily plan and program for them to do some sort of exercise, it kind of keeps them more mobile. You also go do range of motion exercises. This will keep things as strong as possible, but also as, I don't want to say loose, but just being able to have that ability to, because Parkinson's makes you very rigid in contractions. So the range of motion will allow things to be less tight, I guess. Consultation with physical therapy, you want to make sure that they actually have some sort of daily program of exercise, but then physical therapy can actually help you plan that and actually set it up. Walking techniques for safety and balance, because again, these people, the patients with Parkinson's, because of the levodopa, carbidopa, and the Congentin and some of the other medications, they give them that shuffling gait. So walking techniques are going to be very important to keep their feet from shuffling and picking up, or sliding on things, and especially like rugs and hardwood floors and stuff. So a lot of physical therapy can actually help them with that stuff. Do frequent rest periods because they tend to get tired or easily. Do proper shoes to keep them from falling, and then you'll use assistive devices such as canes and walkers and things like that. Interventions is going to be enhancing self-care ability. So you want to encourage, educate, and support independence. Environmental modifications, again, making sure there's no rugs on the floor that they can slip and fall. Make sure they have grab bars in the bathroom. Make sure they're able to hold on to something as they either stand and sit. Use of assisted and adaptive devices. Consultation with occupational therapy. They can help them, give them tricks and tips on how to, be as independent as possible with dressing and feeding and things like that. Other interventions are going to be support and coping. So you want to set achievable, realistic goals. You encourage socialization and recreation and independence. I think this will definitely help with their emotional stability. This allows them to kind of get out there and get out with people and socializing and having some sort of life other than sitting at home and kind of dwelling on what they used to have and what they don't have anymore. Do plan programs of activity. Support groups and referral to supportive services. Again, this is actually to help with family and them coping, and it's also to help with the family and the patient who has Parkinson's cope with, the ability that, they're not able to do as much as they used to before. Another question is going to be, what is anticholinergic medication used to treat Parkinson's disease? We have Congentin, we got Benadryl, Banflex, and neosynephrine, and the answer is going to be Congentin. So Congentin is an anticholinergic medication used to control of tremor and rigidity and counteracts the action of acetylcholine with Parkinson's disease. Benadryl and Banflex and neosynephrine are antihistamines that may reduce tremors, but they're not going to be as good as Congentin or levodopa carbidopa. And that's a pretty fast 16-slide PowerPoint, so on Parkinson's disease. If you have any questions, please feel free to ask. I will see you guys in class, and good luck.